Hello, everyone. Welcome back to the Physio Almanac. We are going to be talking about the musculoskeletal assessment, and we are continuing from the first session that we had on the hypothesis. This time, we are going to be discussing about the subjective assessment. So, what has happened is that we have given the hypothesis or presented the hypothesis to the assessors, and now it's time for us to go and meet a patient. So you would have time, not a lot of time, but maybe a few seconds to a minute to go and collect your equipments that you need, wash your hands, and enter the patient's room. Now, collecting of equipments, you can come between your assessment. So, if let's say you need something and you have forgotten to get that, so it's perfectly fine. You can come take a break while during the assessment, come to the equipment room back again, collect whatever you need, and then you can go back again. Also, about washing your hands, it's suggested, it's recommended, but if you forget, make sure to use a sanitizer in the room and knock and enter the patient's room. Now, this time it can be very stressful, so make sure to take a deep breath and rehearse and remember your patient's name before you go and see them inside the room, so that at least you do not address them by the wrong name. All right, so this is done. Now we are going to enter the room. This is a snip that I have put in from YouTube video, which is on the orientation, simulation orientation. It's from the Australian Physiotherapy Council. And as you can see, there are three rooms. So the rooms with bowls that you can see, that's the equipment room. The one which is next to it is your musculoskeletal room. The middle one is your cardiorespiratory, where you see the bed pole hanging. And the last one is exactly in front of the parallel bars, is your neuro room. And the last area where you see the walkers and the crutches and wheelchairs and everything, that's where you would have equipments available. This is a step that's within the walking area and a parallel bar. So the outpatient room looks like this. Again, it's a snip from the video that is a recommendation to be viewed before you go for the exams. It's available on YouTube, and when they would send you an email about the dates, it would also have in there. All right, so now we are entering the patient's room. So the first thing that you need to do is you will need to take permission to enter the room. That you have done. You would introduce yourself and the assessors. You would confirm the patient's name and age, right? So let me give you an example. So we would knock the door and we would say, "Hello, Mr. XYZ. My name is ABC. I am your physiotherapist for today's session. These are my assessors. They are going to be here watching my session through with you. Is that okay with you?" So you have taken the consent for them to be there and you to be there. And who are you, importantly? Then you confirm the patient's name and age. So before we proceed, can you please confirm your full name and age, or full name and date of birth, just so that I know that I am with the right patient? The next thing we check is a comfort check. So if you see at this picture down next to the plinth, there's a chair. It The patient can be sitting on a wheelchair though, but if the patient is sitting on a chair or a wheelchair, whatever, we have to make sure that the patient is in a comfortable position. Confirm that. So if you look at the picture above, the patient is holding his elbow, so he's probably very sore. So you could ask him, "I can see that you're holding your elbow. Do you mind if I give you some pillows so that you can rest your arm on it? Or would you like to change your position? Would you like to move to the plinth?" Or you would say, "I can see that you do not look very comfortable. Anytime during the session, if you feel any problems, if you have any concerns, feel free to stop me and talk to me so that I can address your concerns." That's another way that you can explain it to them. Or you could say that I can see that you are having a lot of pain. Is that so? I can see from your facial expressions. So the patient would say yes. Okay, are there any pain medications that you need before we start our assessment? Is there anything that I could do to make you feel better so that we can talk and perform the assessment comfortably? So, things like that. Just remember, when we are going for the exam, it is an exam for us. But at the end of the day, we are treating a human being, even though the patient is a patient, right? Even though he's an actor. But it's very important to have that human feeling, to make sure to understand what the other person is going through. So, to put yourself in the other person's shoes, if I would say that way. All right, vision and hearing check. Now, this is not required in all the patients. Yes, if a patient is very older, maybe 70 plus or 65 plus, and just to save yourself, just to make sure, or maybe a traumatic case, maybe a patient has had a surgery and they are admitted to the hospital and you do not know, you're obviously seeing the patient for the first time, then you would have to, it's a ideal thing to just ask, are you able to hear and see me clearly? Now, before you proceed with the proper assessment, it's a good idea to have a quick safety check. So I would check the brakes of the bed, if the patient is on the wheelchair, and look for any equipment which is around. There may be cases where the equipment is there and you miss it. So just have a quick look around, and you can always say to the patient, before we start the assessment, can I have a quick look around to just make sure that I'm not missing out on anything? And it would be a good idea. The next would be summarize the session plan and explain in brief what you would be doing for today's session, right? Then it comes to, have you seen a physiotherapist before? And when why I'm just telling this to you, the best thing that what is expected out of you as a treating physio is these have to be interactive discussions or interactive replies. All right. So let me give you an example. Let's say, um, hello, Mr. XYZ. My name is ABC. I'm going to be your treating physiotherapist for today's session. These are my assessors, W and Y. They are going to be here for today's session. Is that all right if they stay here with us? So the patient says, yes, that's okay. All right. Thank you for your consent. Now, before we begin with the assessment, I can see that you are not looking very comfortable. You are supporting your elbow with your other hand. Is it very painful? The patient says, yes, it is. The physio, do you want me to give you some pillows or would you like to change your position? Do you want to move to the plinth and make yourself a bit more comfortable? No, it's okay. Just give me some pillows, please. So we give the patient pillows and makes him comfortable. Is that better now? Yeah, that's better. Thank you. Now, so I have to say that I think I missed the patients checking the name and age. So we would always say, now, can you please confirm your full name and age? So just so that I know I'm with the right patient. So yes, my name is ABC and I am 25 years old. Okay, thank you for confirming. So in this case, the patient has come to you, let's say in the OPD. So he's less than 65 and he's walked to the OPD. So it's okay. Even if you don't ask the vision and the hearing check, it's okay. Doesn't make any sense for you to ask. All right, Mr. ABC, do you mind if I have a quick look around before we proceed with the assessment? Just to make sure that the brakes are on and we are safe in the environment? Yeah, sure, go ahead. So, yes, I've checked the brakes of the bed. The brakes are on. check the brakes of the wheelchair. The wheelchair brakes are on. All right, I see this brace here. Is this your brace? The patient would say, yes, this is my brace. Okay, thank you. Thank you for confirming. All right. Um, just a quick question. Have you seen a physio before? The patient says, no, I have not. All right, that's okay. So I'll quickly summarize how this session will run today. I have some information about you from your file as to why you are here. However, I would like to understand from your perspective and in detail as to what brought you to the clinic today. And we'll ask you some more questions. We'll be doing some testing of your range of motion, your strength, and then discuss about your goals and plan a treatment accordingly. Does that sound like a good plan to you? The patient says, yes, that's okay. All right. Thank you for giving me your consent. And also, I would like to tell you, Mr. ABC, anytime during the session, if you have any discomfort, any concerns, any problems at all, feel free to stop me and talk to me so that I can address your concerns. Okay? Yes, thank you. So, this is how you would do the first part. Now, again, I have tried, like I was explaining it to you, so I've kind of stretched it, but make sure to keep it quick. All right. Now let's move on. So you have introduced yourself, you have explained about how the session will run today, you have checked the breaks, you have made the patient comfortable. Now what? Now this is the time wherein we start talking to the patient in detail. This is the time we listen to their story and we want to know why the patient is here. Now this can be done in two ways. Either one, you tell the patient, all right, Mr. ABC, I've got your file and I know that you have been referred to the GP after you've had an ankle sprain 2 weeks ago. Is that right? So this is short, simple, and brief. Other way. Mr. XYZ, I have a bit of information that you've got an ankle sprain, I think 2 weeks ago, but I would really like to understand what exactly happened. Can you tell me what happened? Another way. All right. Next thing, you do not have anything from the GP. Why is he here? So you straight away ask, all right, Mr. ABC, can you please tell me why you are here or what brings you to the clinic today? So then, presenting conditions. So what is the main problem that the patient has come to see you? Now, this is a scenario wherein we are talking about the OPD. Let's say the patient is in the hospital, in the inpatient setting. So you would obviously not ask this question, what brought you in today? You already have that file with you, which says that the patient was admitted last night after having excruciating pain due to flare up of his arthritis. So you would, in that case, you would just go, hello, Mr. ABC, I've got your file, and I came to know that you were admitted last night because you were having some increased pain and a flare up of your arthritis. Is that right? So that's how you would begin. So the point what I'm trying to explain it, you make sure to read the file importantly when you are presenting the hypothesis especially, and retain that information. Remember, we talked about you would have some notes with you, some papers, some pens with you. You can take that information with you in the room and you can always read through it and refer back to it during the assessment. So make sure the questions that you are asking make sense. It will not make any sense that you know that the patient, you are an inpatient physio, you know that the patient has been admitted last night, and you just go and ask him, all right, can you tell me why you are here? Like, it may sound a bit off, especially in an inpatient scenario, or especially, let's say the patient has had a total knee replacement or a total hip replacement, and you just going and asking, okay, can you tell me why you are here? You know what I mean? So do not, we do not want to put ourselves in a situation wherein we look and sound stupid. All right, so let's say let's go back to the ankle sprain case. So we would like to understand what happened at the time of the injury, or during the hospital admission, or during post discharge, right? So let's say the patient tells you, yes, I had an ankle sprain 2 weeks ago. All right, can you tell me what happened? Did you fall? Did you trip? How did the injury happened? Can you tell me in detail, please? Now, this is again OPD case. Now, let's say the patient has had a total hip replacement. He was in the hospital and he has got discharged. So we would say that I know that you have had a total hip replacement that was 4 weeks ago. So can you tell me what have you been doing since you're discharged from the hospital? Have you been feeling better? Have you been doing any exercises? And the point is, these questions that are here are just as guiding topics or guiding areas that you should be asking the patient, right? At no point during the assessment it should feel like you have a strict structure in your mind and you are asking questions. That is what a problem the problem is. You have to make sure that you are listening. It's not an English exam, but at the same time it is an example, or it gives the assessors an insight by your questions as to how much you are listening to the patient and how much you are just letting the assessment flow, right? So let's say the patient tells you, oh yes, I've had an ankle sprain, I think 2 weeks ago. All right, it was not given in the file as to how it happened. Can you please tell me what happened in detail? So the patient starts telling you your story. And then, okay, so what would you say your main problems are? The patient would say, I'm not able to bear weight, I'm not able to walk, I'm not able to run, etc. And then few minutes later, you are asking the same question. Okay, so you, let's talk about the social history, or let's talk about. So two things that you have to remember: one, never cut the patient off. Listen to the patient. Empathy is a very, very important part of our role, and you have to demonstrate those skills as well. Other than your clinical skills, as I said before, we have to make sure that we are human beings. We have to kind of put ourselves in the other person's shoes and understand from their perspective. Only when you relate yourself to the patient, think from their perspective, as to a person who is 25 years old, has had an ankle sprain, what would the implications be? Probably not able to drive, not able to go to work. If he's a student, not able to study, submit his assignment because he can't go to the college, whatever. So that thing is very important. And second, listening to what the patient is saying, so that your questions that you're going to ask or your assessment is flowing. All right, it's making sense to the person who is sitting at your back and trying to listen to what you are asking. Okay, so and remember, we as physios are supposed to be good listeners. Okay, so as I said, you can summarize the information that you have to the patient, or you can just not say anything to the patient and ask the patient to tell their story in detail. I prefer summarizing because I feel you're saving a bit of your time. All right. So we would say, then we say we were talking about what happened at the time of the injury. So the patient says, I was playing football and suddenly I do not know what happened, but I think I twisted my ankle. I don't really remember what happened. So are you able to show me a bit on your other foot, that what was the position of your foot when it got injured? So the patient says, no, I don't remember. Okay, that's okay. Do you remember anything vaguely, that whether the foot moved in or foot moved out? You landed on it? So, oh yeah, I think it moved in. All right. So whatever information that you can gather from the patient, that would be good. If the patient says, no, I don't remember anything, that's okay. Don't just go after him and say, no, you have to tell me. It's okay. We will be doing the assessment so we can find out. If he lets us know, it's kind of making our clinical reasoning more helpful and making us come to a conclusion easily and supporting a hypothesis. That's all. But it's okay. Many a times the patient would be able to tell you clearly, yes, I think I moved, twisted it, moved my ankle inside or move my ankle outside? No, I don't remember. I think I landed on my heel. So just see, you can ask the patient, do you mind showing it to me on the other limb or not? Is You can show it to the patient. Do you think it moved inwards? You are showing it on your ankle or your foot. All right. Then moving on, confirm about what the patient's main problems or concerns are. Again, as I said, we are trying to understand from the patient's perspective. We Till the time we do not understand what the patient is going through, we would not be able to help him. And that's the whole point of a person coming to a physio. We are there to help them with their concerns, to help them with their problems, and that's why and to make them feel better. um, so it's very important to understand what their main concerns are. Now, when I'm saying concerns, as I said, 25-year-old male who has had an ankle sprain, his main concern could be that he is not able to go to the uni for his studies. That is a bit of a problem for him, but we got to understand how is that problem related to us? How can we help him? So our concerning problems from our perspective would be, or I'm not able to walk, oh, I'm not able to drive, oh, I'm not able to put weight on my legs, or I'm not able to wear my shoes because there's so much of swelling, or I'm scared to run. I'm not able to run because every time I'm running, I'm feeling that my ankle is going to hurt or it's going to play up. And every time I run, it starts hurting. So, something of that sort. So, we got to understand realistic problems that are relevant to our physiotherapy assessment and treatment. All right. Now, if the patient has been discharged from the hospital, as I was talking about, if the patient is, say, total hip replacement, total knee replacement, then you can ask, were there any instructions from the hospital or any precautions that were given to you? Now, remember, the patients that you would be seeing can have some cognitive decline, or they may not remember uh, because they were not paying attention to what was being told, or they are not, yeah, they're not following it. So it's your duty to remember the what are the relevant precautions and instructions that would be required in case of, let's say, total hip replacement or total knee replacement, or surgical fixation of a shaft or femur fracture. So make sure that you remember and keep a note, whatever things that the patient is telling you, keep a note of those things. And when you are talking about the patient and treating them, at that time you can discuss these precautions again. Now, one of my mentors told me a very interesting thing, and thanks to him, he said, whatever information that you get during the subjective assessment, you have to sit on it. So sit on it. So many a times, why I have seen candidates miss out on the time that they have during the assessment is because, let's say, I am the patient, right? And I start to tell you, you ask me this question, were there any instructions or precautions that were given to you? And I start saying, oh yes, they told me not to sit on chairs, but you know what, I have a low chair at home and that's my favorite chair. I always sit on it, and I cannot watch telly without sitting on it, so I always tend to use it. And my son was saying that I need to get that changed, but I thought, no, 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 I'm just going to keep it with me. So that can also be a situation wherein the patient drags you with that information, and then because the patient has said this, we as a physio, we start get tempted and we say, oh no, 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 you should remember that the instructions that were given, that you were not supposed to be sitting on low chairs, and remember, you always have to keep your hip and knees at 90 degree, and see, I'll show you, this is how. So we get dragged into the patient's story. That is what we have to stop, right? The first part, the subjective assessment, we are just gaining the information. We are just making notes. So, as I said, you would have a paper and pen. The patient tells you that they don't remember the precautions, they don't remember the instructions. Just make a small note of it. And when you come to the treatment part, it is at that time when you revise those precautions. Because so much that you have to save time in the subjective assessment, but also make sure that you do not miss out on the other things. And we are just listening to the patient in the first part. And if you go into some conversations that have taken way longer than your time, then I have seen people not being able to finish or reaching even the treatment part. So, just a little bit of reminder there. All right. So, and then you can ask if the patient has seen any other health professional. Let's say the patient tells you, yes, I'd had an ankle sprain. Then you ask him, okay, so what happened? You were playing and then you twisted your ankle, and were you able to walk? Were you able to um, take a few steps to come down to the side of the court? What happened? So he would say that, no, I was not able to walk. So my mates helped me, lifted me, and I had to get some ice because my ankle was pretty swollen up. So, okay, did you go to the GP after that, or you have come to us directly? No, I went to the GP and they told to come and see you. Okay. All right, that's okay. And other than going to the GP, have you seen any other health profession? Have you seen any other physio? Have you got any massage done? No, no, no. I've just been to the GP yesterday and today I've come to see you. All right, thank you. Let's move on to the second part. So, this is how you would explain and you gather information about the presenting condition or about the presenting complaint that brings the patient in. Okay, moving on to the pain assessment. Now, again, we are talking about OPD cases first. So, there are two ways of doing this assessment. The second one, which I do not really like, I've put it in the second slide, but this one, let's talk about it. So, we would like to understand the given information. We would like to understand what is the site, what is the side, what is the type of pain, what is the nature of pain and associated symptoms, intensity, aggravating factors, relieving factors, 24-hour pattern, sleep, and pain. Okay, so let's talk about it. So the patient says pain on the ankle. We have to understand, okay, which side of the ankle? Is it the outer side or is it the inner side? So you can ask the patient, can you pinpoint on the ankle and show me where exactly are you having the pain? And why are we doing this? We are making a hypothesis. We are creating a probable diagnosis if that's not given to help us. And all this information would be helpful. All right. Is it the right ankle or is it the left ankle? Okay. Or you would have already got that information when you were talking about the presenting condition. Okay. What is the type of pain? How would you describe your pain? So many a times the patient may not understand this question. So you will have to give prompts like, do you think it would be a dull ache? Or do you think it's a very sharp pain? Or you feel it's like a catch? Or is it a burning kind of pain? So the type of pain, sorry, would help us to understand what could be the probable source of symptoms, what could be causing the pain. Next is, all right, uh, I do understand that you are having this pain. Now, would you say that your pain is present all the time or it comes and goes? So that asks the question about whether the pain is constant or intermittent. Now, if the pain is constant, unremitting pain, it's usually a red flag. We will talk about that later. And if it's intermittent, it's pretty normal to have intermittent pain. But why I have not used the word intermittent, many patients may not understand. So make sure that you do not use any medical jargons during your assessment and keep it as simple as possible. Again, you do not have to ask, okay, tell me the exact site of pain. You can use, okay, can you tell me the exact location of the pain? All right, how would you describe your pain? And describe your pain would answer, I'm talking about the type of pain. Then you would say, okay, is your pain continuous or constant, or it is intermittent, like it comes and goes? Now, are there any associated symptoms, like along with pain? Have you noticed any pins or needles, any tingling, any numbness? The patient would answer that. Um, and many a times they would not be able to understand. So you would have to say, do you feel any funny sensations? Or do you feel any ants crawling on your hands or legs? Something of that sort. Okay. Now, intensity, that is a visual analog scale. All right. Now, thank you for, like, I'm still, you would say that to the patient in, so I do understand that your patient pain is on the outer side of the ankle and or of your left ankle, and it is a dull ache kind of pain, right? And it comes and goes. If you have to tell me about the intensity or how severe your pain is, so ideally the recommendation, because the name is a visual analog scale, the best thing to do is to draw the scale. So the visual analog scale means it's a representation of the intensity of the pain, right? It's of how severe the patient is. And as the name suggests, it's visual. So many a times we would see that we just ask that, okay, out of a scale of 0 to 10, how much would you rate your pain now? So you would have the paper and pen with you. You might as well just draw 0 to 10 as I have drawn it here. A quick thing, and you would just say that if 0 means no pain and 10 means the maximum pain that you could ever imagine, that means you might have to go to the hospital emergency department. How much would you rate your pain now, at rest, and on movement? And you can all, don't confuse giving a lot of information. Okay, 0 is this, 10 is this, 5 is this, 3 is this. So we are not really putting words in the patient's mouth. We have to be um, very true of about how the patient feels the pain is. So a quick thing and a good idea is to draw the scale as you have the paper and pen with you. And again, you can do use a body chart as well. So when we were talking about the site and the side and everything, so you can draw a quick stick diagram kind of picture, or a quick um, representation of the human body, and just ask, okay, this is the site of pain, and okay. And then for the visual analog scale, you can just draw from 0 to 10, where 0 means no pain, 10 is the maximum pain. How would you rate your pain now, at rest? So a good thing is to have two values, two numbers, one on rest and the other on movement. All right, so let's talk about aggravating factors. So we would again, do not ask the term aggravating factors. You can just say, all right, Mr. ABC, can you tell me what causes your pain to increase? So you have told me that your pain increases to 6, but what are the factors that causes the pain to increase? What do you do for your pain to increase to 6? All right. And many a times you would notice that you have to ask your questions in different ways, so just so that the patient understands and is able to answer your questions correctly. And what makes your pain better? What relieves your pain? Or what causes the pain? What decreases your pain? So the patient would say rest, pain medication. Some may say heat packs help me, or warm baths help, something of that sort. Now, another thing that you need to know is the 24-hour pattern, and we need to ask. So, again, not asking what is the 24-hour pattern, the patient may not understand. So, you would just say, like, I've got all this information about your pain. I just have a few more questions. So, do you think that there is a particular time of the day that your pain is more? Or do you think that like, evenings are more painful? or mornings are bad, something of that sort. Now, if you've got the history, let's say the patient has low back pain, so then you can also ask, all right, so have you noticed that on the days that you're going to work, wherein you are at work, wherein the patient's work involves heavy lifting or something, have you felt that your pain is more on the weekends or it's more on the weekdays, something of that sort? So, morning pain can be related to the inflammatory process. Usually, patients who have arthritis would report of pain more in the morning, and evening pain at the end of the day can be more of fatigue related pain. All right, the next question, is your sleep getting affected because of the pain? Or you could also ask, how is your sleep going? And again, it is very important to ask this question, especially in surgical cases. And I tell you the reason why. Recovery is very much dependent on how much rest is the body getting, or how much time is the body able to get to recover from the surgical process, or to recover from, you know um, a surgical procedure. And if the patient is in a lot of pain and the sleep is not there, or if not a surgical process, if the patient is having a lot of pain due to arthritis, let's say, and he's not able to sleep, so when he tries to get up in the morning, he is still sore. So it goes into that vicious circle wherein he is sore in the morning and he does not want to do any exercises and he does not want to go for any walks, or after a surgery when you want him to do some exercises so that he can get his range of motion back, but he's not been able to do any exercises because he's in pain. And why is he in pain? Because he's probably not taking enough medications, or the medications that he has been prescribed are probably not uh, what he requires. He probably requires something stronger at this time. So that's why I've put 24/7 there, just to give you these little prompts. And if you look at the picture at the top, wherein the lady is putting her hand on the back, the patient may just describe it vaguely. Oh, I have pain on my back. But you need to localize and understand, on the left side, on the right side, in the center, where exactly. How would you describe your pain? Then, all right, is your pain present all the time, or it comes and goes? How severe do you think your pain is? All right, can you tell me what are the things that increase your pain and what makes it better? All right, and have you noticed that your pain is more in the morning or more in the evening? And how is your sleep going? So, this is again the points that in the bold are there for you to remember as prompts. We have to make sure that we ask the questions in the best simple way possible. All right, moving on. This is Voxnor, which is another way to remember the pain assessment. To be honest with you, I have never really used it. You can use it if you want to. I prefer the pain assessment the other way that we have just discussed. All right, moving on. Remember, now this thing is important. If it's a surgical case, then the detailed assessment is not required, right? So it is kind of assumed that the patient has had a total hip replacement, total knee replacement, or an internal fixation of the humerus fracture, let's say. It is obvious to have some amount of pain, and this is what I was talking about. You have to make sure that the patient is getting enough of pain medications so that he is able to participate in rehab. Let's say the patient comes to you and tells you that, no, I have pain, but I've had a surgery and I have pain. All right, so we would ask, how much is your pain out of 10? So we would say, the patient says, oh, it's just 2 out of 3. All right, that's not too bad. Are you taking any pain medications? The patient says, yes, I'm taking endone. All right, so that's good. Second case. Oh, I've had a surgery. Yes, I am no, I am fully aware about that. Do you have any pain at the moment? Oh, yes, I have a lot of pain. Okay, how much is the pain out of 10? Oh, I think it's an 8 or 9. Okay, that's a big number. Have you spoken to this about with your doctor? Oh yes, I want to, but I've not been able to. All right. I would really suggest for you to go and speak to your doctor because we have to make sure that your pain is well managed before we can actually participate in physiotherapy treatment. Because if you are having so much of pain, you may not be able to participate in rehab, and that would delay your recovery. Or the patient would say, "Oh, I'm in so much pain, I'm not able to sleep in the night." Have you spoken to this about with your GP? No, I've not spoken about your GP. I think it would be a good idea to just discuss with your GP, and I am happy to write a letter to your GP as well, and just explaining your situation about how you are feeling, because we have to make sure that you are sleeping well, your body is getting enough time to recover, and you are able to do the exercises the next day. We really want you to get back on your feet really soon, and management of your pain is very important. So, as I said, you do not need to understand what is the aggravating factor or what is the kind of pain. Yes, you do need to understand if there are any sensory deficits, any um, pins or needles or any associated symptoms, but not going into too much of detail. Make sure if it's a surgical case, the patient's pain is well managed. That's important so that he can participate in rehab. All right. Again, another important thing that you have to remember is, let's say the patient had a surgical procedure 6 weeks ago. So by 6 weeks, you are expecting that the patient should not be having a lot of pain as compared to a patient who has who's had the surgery 2 days ago. Do you understand? So you have to correlate, when did the patient have the procedure or have the surgery, and when are you assessing him? If the patient has had a surgery 6 weeks ago and you go and see him and say, "Oh, yes, I'm in a lot of pain. The pain's excruciating. It's 8 out of 10," then that means there's something wrong on the surgical site. And then when you do an assessment, you see, oh, it's red, it's inflamed, and it's hot to touch, and it's super tender. You need to rush the patient to the emergency department. So make sure to correlate the patient's pain intensity, what the patient tells you, with the duration since when the surgical procedure happened. So it's very important to have a bit your ears and your mind open when you're doing the assessment. And as I've said before, listen and talk to the patient. Keep yourself in the patient's shoes. Moving on past medical history, then you can just say it in this way that, thank you, Mr. ABC, for providing me with all this information about your pain and how the symptoms started. Now, I would like to understand about your general health and well-being. So, I do understand you're 25 years old and you're pretty young, so I'm not expecting any major health issues, but I still want to do a quick check. Have you ever been diagnosed with having thyroid issues? Have you ever had high blood pressure, low blood pressure, any blood pressure issues, any arthritis, epilepsy? So these questions can be just a yes no answer. Again, if it is given in the file already, then you can make it even more easier. Yes, I read in your file that you have asthma. Is that well managed? Do you have an action plan in place? And do you have your puffer with you today? So for asthma, make sure, because you're going to make the patient exercise, make sure that the patient has his puffer, and it's a good idea to cite it. So can you show me, where is it? Oh, it's in my pocket. All right, can I have a quick look at it? So it's important for you to cite the puffer. He says it, oh yes, in the pocket. And when you're doing the treatment, he gets short of breath, and you would say, okay, can you take your puffer? Oh, and he's looking for his puffer. It's actually not there. So don't put yourself into trouble. Just make sure that he has the puffer and you see it. So these past medical history questions can be a simple yes or no questions, and you can just ask, have you had any recent surgeries um, that may be related? So the patient has come to you with neck pain, and you probably forget asking about any recent surgeries. And when you are about to ask the patient to come and walk to the plinth, he tells you, "Oh, I have some trouble in my knee. I had an surgical procedure done a week ago." So don't put yourself in this condition wherein you do not know what to do. So make sure to collect all the information in the subjective assessment so you are very well prepared for your objective assessment. So a quick easy way to remember is the threads. So as I said, simple terms that you should be asking the patient: high blood pressure, arthritis, epilepsy, they normally understand. Asthma, they understand high blood sugar, and surgery. All right. And a good starting line can be: we have got this information about your presenting complaints and why you are here, but I would like to understand about your general health and your past medical history. Are there any medical conditions that I must be aware of? Now, the patient, you have read his file and it's given that the patient has epilepsy. So, what you can say: I've read your file and I do know that you have epilepsy. Is that being well managed? Okay. Any other medical conditions that I must be aware of? Any high blood pressure? Any high blood sugar levels? Something of that sort. All right. Moving to red flags. Now, red flags is can be different for all the cases that you see. You do not really need to have the same standard red flags. So the standard red flags would be, so let's say you can ask, have you had any unexpected weight loss? Or is there any family history of cancer? There's no point in you asking, do you have any bowel or bladder problems for a patient who has shoulder pain? So you could ask, do you have any unremitting pain, any pain that is not settling down, as we were talking about continuous pain? In surgical cases, you could ask, do you have any pain at the back of your legs? So it gives us an indication of deep vein thrombosis. Or have you had any unexplained fever? So these are the red flags that you could ask, but make sure that they are relevant. So let's say a patient has neck pain. You could ask, do you have any dizziness or do you have any visual disturbance? Do you feel any nausea, any vomiting? Or let's say the patient has low back pain. So do you have any bowel or bladder problems? Do you have any sensation issues that you would have noted? Or do you feel weak in any of your legs? Or have you noticed any changes in your walking pattern? So things like that, you should be uh, adjusting the red flags according to your patient's case. That's the whole point. So do not ask red flags just because of the sake of asking. We are trying to rule out if there's anything sinister, anything which requires urgent medical attention and intervention rather than you treating the patient. All right. So that's the purpose of asking red flags. So make sure they are relevant to the topic that is being discussed or addressed. All right, let's move on. Current level of function and previous level of function. You would have seen these terms as PLOF and CLOF. So again, it is important for you to compare the previous to the current. Now, how far do you go, right? How far into your previous history you go? So in terms of a shoulder pain, let's say, or a neck pain, the patient has been having some pain in his neck and it started round about 6 months ago. So your previous would be 6 months before and now, current. Okay. Or patient has had an ankle sprain. So now ankle sprain is not something you would ask 6 months ago. Before this injury, you can say, or 2 weeks before this injury. So the patient has had then the injury for 2 weeks. So 2 weeks before. Now again, you have to make sure that when you are asking this question again, and I'm just thinking that at times we may ask questions which may make us sound stupid. So let's say a 25-year-old female or male who's saying that he was playing basketball, and you ask him, okay, how far were you able to walk before you had this injury? So he's telling you, or she's telling you, that they were playing basketball. So it is kind of an assumption that's a high level activity, right? So they would be able to walk. So if you ask them in such a way, it may sound, oh, why is he asking me that? It, Another way to put this question would be, so I'm assuming you're pretty young and you were playing sports, so you would not be having any limitations in your walking distance before you had this injury. Am I right in saying that? So this is another way to prove yourself that you're not stupid and you know what you're asking and why you are asking, if I'm making sense. So, but yes, if it was a 59-year-old male who has a diagnosis of osteoarthritis and has been having pain on his bilateral knees for the past 3 months. So your previous level of function would be 3 months ago. How far were you able to walk? And how far are you able to walk now? So that is how you are comparing previous and current. Do you use any walking aid? Now, again, 59-year-old male, it's okay to ask. You do not expect that from a 25-year-old, how you would ask. So, you've had this recent surgery on your ankle because of the syndesmosis injury and surgery that you have. Were you prescribed any walking aids? This is the question that you would ask. 25-year-old male, it's not, who's had an ankle sprain, not necessary for you to ask, do you use any walking aid? So, or when you entered into the room, you would have seen that crutch that we were asking when we were looking around. So, the crutch that you're using, and you can point out to the crutch there next to him, this crutch, who gave it to you? Is this your crutch? Who prescribed it to you? So, again, modify your question based on the patient's age, the patient's presentation, and what you are seeing. And a very good idea would be to practice the cases. And what I'm trying to do here is I'm trying to talk through different scenarios that you can think about and put into practice so that it can help you a bit. Okay, so for lower limb, we would ask questions: how far were you able to walk? Or how far are you able to walk? Do you need any rest during the walk? Do you use any walking aid? And what stops you from going further? For upper limb, we may be able to ask, are you able to reach at your back? So we are talking about more of functional limitations in this case. Are you able to close your bra? Or are you able to button your shirt? Are you able to perform overhead activities, like hanging clothes on the line or combing your hair? For a person who is a chef, you may be able to ask, are you able to work easily in the kitchen, or are you able to are you having problems to reach overhead cupboards, something of that sort. Now, moving on, falls history. Now, falls history is not required to be asked for every patient. Important for a patient who is more than 65 years old, and we we are trying to confirm if the patient has had any falls in the last 6 to 12 months. So you can just say, so Mr. ABC, can you tell me if you've had any falls in the last 6 or 12 months? Okay, and the patient says yes. Okay, so where did these falls happen? Were they inside the house or outside the house? Okay, and do you know what happened? How did you fall? What time of the day was it? Were you able to get up after you had the fall? And in the meantime, you are pausing because you are waiting for the patient to respond. And were there any major injuries? All right, that's okay. Now, as I was talking to you before, we do not have to reply to the answers that the patient is giving to us straight on. Sit on the information that you get, right? So the patient is telling you that he has been having some falls, so you are thinking about Can it be a balance problem? Can it be a vision problem? Is there some proprioception deficit? So you are trying to narrow down your hypothesis as to what could be the probable cause, and all these would be confirmed when you do your objective assessment. The treatment, remember, when we are doing the treatment, then we are going to talk in detail about the falls and what he can do to prevent those. All right, moving on, the personal and social history. Now, this is, we can say, we are almost at the end of your subjective assessment. It includes questions like the house setup, help at home, occupation, hobby, smoking and alcohol, right or left handed, and driving. So you would say, so let's talk about, thank you for giving me all this information of what we have discussed, or thank you for providing me with all the above information. There are a few other questions I need to ask, and we will then follow with the second part of the assessment. So, can you tell me about your house setup? So, straight off, if you ask, okay, thank you for providing me with all the information. Tell me about your house. So, it would look very odd for the patient, and he would think, oh, why is he asking me about the house setup, right? Then again, now, if the patient has a lower limb injury, it still makes sense for you to ask whether you live in a single story or a double story house, or in a house or an apartment. Are there any lifts? If a patient has a shoulder problem, I don't think that it's very relevant for you to ask, do you live in a single story or a double story house? The shoulder problem may not be affecting his walking ability, right? So you can skip that question out. And that's what I'm trying to make you understand here. The questions that I have put in, you have to modify your assessments based on the case that you have got. And not everything that is here has to be asked. You have to understand that you have to plan, accommodate, adjust your assessment as you go and see the patient. All right. So again, lower limb, if the concern is there, do you live in a single story house or a double story house or an apartment? Are there any steps or stairs inside the house? How many are there? Are there any rails? If yes, on which side are the rails? Are you having any difficulty to access those steps or stairs? Um, whom do you live with, Mr. ABC? The patient says, I live by myself. Now you are trying to understand, okay, so this is a 59-year-old male who's been having pain in his bilateral knees, has a flare up of his arthritis, living by himself, does not need does not have any support, so we might need to provide him with some support, so again, the questions that you are asking, you are trying to develop a plan in your mind to be able to help and guide the patient. Occupation, we need to understand whether the patient is a student or working. And if the patient tells you, yes, he's working, so what is the type of work? The patient has been having back pain for the past 6 months. Is it something he's doing at work that is aggravating or that's causing the pain? What's happening? So we need to figure that out. Hobbies. What does the patient like to do in their free time? And this can be useful for a patient, let's say, is very depressed and he's just lost his partner, and you want him to get out of the house so that he can feel a bit better. And he's been having low back pain and he's lost his partner, and he used to play golf, say, before. So you want him to get out of the house. So a good way, if you get all these information, all these questions are actually not only trying to develop a rationale for your treatment, it's also helping you to develop a rapport with the patient, which at the end of the day is very important for them to be adhering to the treatment protocol, and also for their benefit as well. All right. So for long-term goals, you can ask them about their hobbies. You could also ask about whether they smoke or drink, and as I was telling you before, that we do not have to go into that situation where the patient starts telling you your story and you waste a lot of time. So just ask a simple question: do you smoke? And the patient would say yes or no. All right. Can you tell me how many cigarettes do you smoke in a day? I would say 20. All right. And how many years have you been smoking since? These many. Okay. Just letting you know that smoking can affect the healing of the bone and the soft tissue. So while we are recovering, if you can at least try to cut down on your smoking, would be a good idea. And alcohol can affect the capability in capability of recovery, I would say, and in such a way, because the patient may be taking some medications and the effect of the medications may not be achieved to the best because of the alcohol. So you can just ask and advise and recommend, but obviously you cannot really impose anything onto the patient. Right-handed or left-handed, it's very important in neuro cases, but it is also important in upper limb injuries. Imagine a patient who's been having tennis elbow. He's a chef. He's right-handed, and it's his right elbow that's troubling him. So you got to think of alternative strategies, and again, preparing your treatment or planning your treatment. These questions would help you to suggest him alternatives that would be helpful for the patient. Driving also is important in upper limb injuries, and to a certain extent in lower limb injuries as well, depending on whether he has a manual or an automatic car, and whether he is able to attend the physiotherapy appointments. Because let's say if they are not able to, then outpatient clinic, then you might have to think about arranging community transport and things like that. So a good idea to have all these things documented. All right, so I'll just go back to the previous slides. So remember, we meet the patient, we check their comfort, we do a safety check, we summarize what we are going to do in the session today. We ask about why they are here, ask in details about their main problems. Then we do a pain assessment, ask about all these questions that what we have already discussed. We then talk about their past medical history, clear out the red flags. Now, again, one thing I think I forgot to tell you: do not have to say, okay, there are some red flags that I need to clear. You don't have to tell that to the patient. When you are talking about the past medical history, you can just ask in continuation, I just need to ask you some mandatory questions, just making sure that there is nothing urgent that needs medical attention, or just asking you some questions just to make sure that there's nothing significant going on that could be a worry for us, something of that sort. Don't use these terms red flags, it can scare the patient. Current and previous level of function, falls history, as I said, it's important for patients at 65 years old, personal and social history. Now you have got all this information. What do? You summarize the information obtained to the patient. Now, again, I do not want you to say, okay, I know that you live in a single story house with your brother and you are a student. No, we do not want this, right? Remember, we are having a time constraint. We have to be sensible and we have to be very mindful of our time. So, a quick way to summarize would be, all right, thank you for providing me with all this information, Mr. ABC. What I gather is that you sprained your left ankle 2 days ago while you were playing basketball, and at this time, your pain at rest is 6 out of 10, and it increases to 8 out of 10. You have been taking some pain medications that has been helping you. You have not been a physio before, this is the first time you are coming to see me. You live by yourself, and you're a student, your work's getting affected, and yes, that's all. That's the main points that I have highlighted. Is there, and then you ask, is there anything else that you would like to add to the above that would help me to assess and treat you better? Or you could ask, is there anything else do you think that is important for me to know? Or you could say, is there anything else you think would be helpful for me to know? Or is there anything else that you want to add to the above information? All right. Again, we are summarizing. We are not repeating the whole assessment in detail. And why are we doing this summarization? We are doing this so that we have a background for our goal setting. The goal setting is the last component of your subjective assessment. You would just say, all right, let's talk about your goals. So, what is something that you would like us to work on for today's session? For the purpose of the APC exam, today's session is your short term goal. When you're seeing a patient in the clinic or in the hospital settings, you would say, what is something that you would like to achieve in few weeks to months from now? And long term would be a longer term, like maybe 6 to 12 months. But for the purpose of the exam, short term goals are what is something that you would like us to work on for today's session? That is your short term goal. And what is something that you want to achieve in the next 3 to 6 months from now? Is your long term goal. Simply stating, you would just say, all right, we have got all this information and let's talk about your goals now, and say it very loud and clear. Let's talk about your goals now. So, in terms of your short term goals, what is something that you want us to work on with you for today's session? And what is something that you want us to work with you in the 3 to 6 months from now as your long term goals? So, this is how you can talk about your goal setting. Remember, there are additional points and marks for your goal setting. So, don't miss out on this. It's very important. And not every time you may have something known as SMART goal set. I'll talk to you in a minute about that. But make sure if your goals are not making sense, make sure, or they are not aligned or not conforming to what you think would be good or what the patient would need, make sure to come back to it before you start your treatment. So that means after your objective assessment. Now, I'm sure you would have heard about something known as SMART goals. What is SMART goals? Your goals should be specific. Your goals should be measurable. Your goals should be achievable. Your goals should be relevant. And your goals should be time bound. So, we have already spoken about being time bound. So, it's within the next 3 to 6 months or today's session or the next few weeks. They have to be relevant to the patient. Remember, the assessment that you are doing is trying to understand the patient's perspective, but it should be relevant to the patient, right? These are not our goals that we want to achieve. These are the patient goals. Again, the goal should be achievable. Let's say the patient has had a patella dislocation and he tells you, okay, and he's come to you, right? He's just been treated conservatively and he comes to you, oh, I have a marathon that I need to run on the weekend and I have to go. Do you think that you telling him that, all right, yeah, that's a very good goal and let's work on it for today's session? No, that's not practical. That's not sensible and that's not achievable. Because if you think about it from a physiotherapy point of view or from a sensibility point of view, a patella dislocation which has just happened maybe a week ago, it will take some time to heal. And you telling the patient that yes, you can go and run a marathon on the weekend when he is still not in the phase of healing, that should be ideal. It's not logical, right? So make sure that your goals are aligned, which are making sense, which are relevant, and which are attainable, right? Now, measurable. Let's say, again, when we are doing the objective assessment, we are doing a range of motion test or we are doing the strength assess. So these are objective outcome measures. If the patient tells you, I'm feeling fatigued, I'm feeling tired, so, and you just say, okay, that's okay, and you do not have a number linked to it, you cannot quantify it, you cannot measure it, that means there is no point of setting a goal. So, let's say the patient is having limitation in dorsiflexion range of motion, which is reduced to 2 degrees, let's say. So our goal would be to be able to achieve dorsiflexion range of motion up to 10 degrees in the next 2 weeks. So that goal is time bound because it has a time. It is relevant to the patient because he needs to be having his range to be able to his do work. It is achievable because you know that you can work on it and you would be able to implement exercises that would help you to achieve that, and is measurable. So from 2 degrees to 10 degrees, you have an outcome, objective outcome measure that you can assess in the next 2 weeks, right? So your goals should be making sense. Now, you do not have to tell this to the patient, that the patient would say, I want to be able to move my ankle more. That's the patient's language. And he would say, okay, that's fine. But how I would frame it, you tell the patient, that's how I would frame it. So I can see your range of motion of the ankle moving upwards, that's the dorsiflexion range, is limited to 2 degrees. How about in the next 2 weeks, we try to increase the range of motion to be to up to 10 degrees? So, is that a good goal? So, we are telling the patient, and many a times you do not even need to tell the patient. You just need to keep it in your mind for you to be able to keep a track of the patient's progress. So, importantly, the goals are to be measurable. Now, the goals are to be measured, right? In terms of your fatigue that I was talking about, the patient tells you that on out of scale of 0 to 10, I feel 8 out of 10 fatigued when I'm doing the exercises. Okay, how about we try and increase this number? So, slowly, as you are progressing with the exercises, we would expect this number to reduce, right? We would expect it to get better. So, let's say, okay, how about we work on making it less than 8 in the next 2 weeks? So, again, measurable goal, quantifiable goals, specific. Now, make sure your goals are specific, they are clearly documented. When you are saying improve the ankle range of motion, what range of motion are we talking about? Are we talking about the dorsiflexion? Are we talking about plantar flexion? Are we talking about inversion? Are we talking about eversion? Make sure to be specific. The patient says, to be able to increase my walking distance. That's what your patient says your goal, his goal is. So increase your walking distance by how much? How much is he able to walk? What is the time? How many days he wants to be able to walk? He's able to walk 50 kilometers, let's say now, 50 meters. He wants to be able to walk 100 meters. Okay, that's a good measurable number, but by when? By tomorrow? No, that's not realistic. That's possibly not achievable. Yes, if the patient says in the next 3 weeks, yep, that sounds good. So that's time bound because it is 3 weeks. It is relevant because that's what the patient wants to do. It is achievable because we have 3 weeks for training that we can attain this goal. We are able to measure it because we are counting from 50 meters is the previous and 100 meters, that is the target. So you can measure the improvement, and it is specific. You know that you are trying to increase the walking distance, um, and you can specify it even more on outdoor areas. So that's how goal setting should be. Again, in the exam you may not have a lot of time, but make sure that your goals are relevant to the area in concern and to the patient. You are not there to set or impose your goals. You are there to set the goals with the patient for the patient. So the patient may say, um, I want to go and run a marathon. And you would say, oh, yeah, that's a very good goal. But we have to make sure that it is realistic, it is making sense. And do not think that because you think that increasing the walking distance would be more important before the patient starts running, which is realistic. You try and explain to the patient. If he gets it, he gets it. If he does not, then we may have to try other ways to convince the patient. All right, that was all for the subjective assessment. Please follow for the objective assessment. And yep, I'll see you in the next one. Thank you. I hope this was helpful. Talk to you soon. Thanks.